Have you planned anything from there for them? Are you going to take them somewhere? So plan something, otherwise they will drive you crazy. They will wake up 7 o'clock in the morning and be on your face. That's the first thing they will do. They can't see you sleeping.
That's the paradox, isn't it? During school time, don't get up in the morning. During holiday time, up at the crack of bloody dawn.
Yeah.
Pardon my French.
And they're just on your face like this. When are you going to wake up? When are you going to wake up? This is the question they keep asking.
Yeah, that's God. It.
Okay, if it's all right, shall we start, everyone? So good afternoon, everybody. Welcome to our February GP Forum. Happy Valentine's Day to everybody. We've got a nice agenda today. We've got a few notices, we've got Q&A, we've got LMC, then we've got our cancer screening project that we're going to find out more about. I want to just take this opportunity to welcome some colleagues to our team, so to speak. So we've got some new clinical leads that have been appointed. So we've got Dhiren Dayal, who's our new CVD lead, who's a clinical pharmacist at Market Street. We've got Dr. Rahana Aslam, who's our planned care and frailty lead, who's a GP at Claremont Practice. And we've got Dr. Chetak Barrett, who's our new cancer lead, who's working at Wordsworth Health Centre. And I think we have got Chetak here with us. So I don't know if you want to say hi to everybody, Dr. Barrett.
Hi, everyone. My name's Chet. I work at Wordsworth day to day, and I have been named as the clinical lead for cancer for Newham. So I'll send an email out at some point, but please do get in touch with me if there's any issues or otherwise you'll be hearing from me from some potential projects and stuff moving forward. But yeah, hopefully looking forward to working with you all.
Brilliant, thank you. And just that we've got the cancer screening project that's going to be discussed later, so please do share any input if you'd like as well. I don't know if the other clinical leads, I think Rahana's on leave, I believe, and I think Dhiren is on leave as well, but hopefully we'll have the opportunity to meet those two colleagues as well at a later date. Okay, so first item on the agenda is notices. We've got Paul that's going to be mentioning a few things, so over to you, Paul.
Thank you, Arpana. Hello, everyone. Hi, I've got 3 notices to share with you. So first off, we've got an announcement news around the GP Teamnet portal that all practices have been using for the past 3 years. So that's been funded by NHC, and we've renewed the license arrangement. So that's now being onward supported and funded for all practices. And that portal you can use for a range of clinical and management support purposes. It has a policy library. You can do all your personnel management and is fantastic for CQC compliance. So all the compliance activities you need to do around safety alerts, significant events, management, and complaints and premises and fridge monitoring can all be managed on that GP Teamnet portal. So that's really well used across Newham. So just pleased to announce that that's been onward funded and available for practices. So no one needs to do anything there. It will just continue being made available. So that's the first announcement. Secondly, we've got the results of the recent ballot that went out to all practices, and that was asking members around changing or increasing PCN representation on the NHC board. And we had a great turnout, and the vote 63% was yes in favour of increasing PCN representation on the NHC board. And so we will be taking that forward with discussions at the next NHC board meeting and reaching out to PCNs how best to do that. So that's really positive. And then finally, just a reminder to everyone, we have the ARI clinic still running to the end of March, and just to remind practices to keep utilising that service and just referring patients in there. So if anyone has any questions, please raise now or contact NHC for more information over the month.
Thanks, Paul. Any questions for Paul? Wax.
Well, you said the increasing PCN representation. Just quickly, who was balloted? So who did the voting stuff go out to? And then secondly, any thoughts on how we're going to address conflicts of interest?
Yeah, so the first question, who did it go out to? It went out to every single practice. So each practice was asked to submit a vote and was followed up. So every practice would have received a formal voting request or slip, and then the ballots were returned. So that's every GP practice in Newham, all the members of NHC. So that's the first part. The second part, in terms of managing the conflict, very much as is the current process, we have a conflicts register, and all board members declare those and are made aware to members and to the board themselves. So we already have a number of clinical directors on the board, and basically we ask all conflicts to be shared, and so that is transparent. Max?
So people step out of meetings where decisions are being made when appropriate. Yep.
Correct.
Thanks.
Yeah, any other questions for Paul? No. So just to say thanks to NHC. So as a member practice, I am appreciating the fact that that Teamnet has been gifted to us, so to speak, and the NHC is continuing to do that. And just with my NHC hat on, I know that NHC is working to look to see how else that they can support practices going forward. So, you know, we're happy to hear from things that you feel that may help you as well. Okay, so the next item on the agenda is our LMC team. And I saw Danielle's joined. Have we got Tammy with us as well?
Yeah, Danielle and I are here. Hi. Sorry, I thought we had I thought there was an item in between us. Never mind. Hello, everyone. Happy Valentine's Day. Yes, there's lots going on in Newham, as usual. And we thought we'd give you a bit of an update from an LMC perspective. So Daniele, I can't suddenly ask you.
I'm here.
So should we just do a quick update with where we've got with some of the Liz reviews?
Yeah.
It's a little difficult for us because there haven't been any formal comms from the ICB as yet. So a lot of what we're saying will be around, you know, sort of just our perspective and kind of what our ask is. So I'm going to just hand over to Danielle, if that's okay. Thank you.
Yeah, thank you, Tammy. So yes, in terms of the locally enhanced services for 25-26, so April is approaching really fast. So we are continuing the discussion with the ICB on the service review for now that they are undertaking. It is a big ask and a big ambitious project, and from an LNC perspective, we have raised concerns about the limited resources that there are in the ICB to undertake this piece of work, and the concern of the impact of this on the timescales. Because obviously we want this to be not like a 10-year project. You know, we would like the review to happen sort of within some realistic timescales. What the ICBs are telling us is that the plan for 25-26 is to roll over the schemes that are in place for 24-25. So we have already done in the last few months quite a lot of tweaking of the schemes with the ICB, and so we welcome from one point of view the early clarity around what is going to be rolled over for next year. because we don't want to be in a position like this year where it was September and we still weren't sure. However, we do have some concerns around, for example, once again the lack of any uplift on the LCSs, and of course the fact that there are still some specs that are coming to us with some significant changes. For example, the care home specs that has been circulated already to practices, a mental health spec that seems to be one of the key areas of focus at the moment for us with the ICB, and also a new proposal for the PES for the is it pharmacy and efficiency scheme and quality schemes, which we are currently having discussions with the ICB. So I think some of the themes that I just wanted to sort of briefly describe is really the fact that for all of these things, there seems to be very limited funding for the amount of asks that are asked to general practice in the specifications to do. And I think our message is very clear that general practice cannot be expected to do more with less funding. So we really need to think, we're going to have to think, and practices will need to think whether these lasers are going to be affordable for them. We're also concerned about the appropriateness of some of the elements that are being included in the spec for general practice, like for example, things around ADHD, etc. So again, we'll continue to push forward with clarifying those with the ICB. And then finally, some of the unrealistic targets that have been put in this spec. And again, we're negotiating with the ICB to make sure that they're kind of like data-driven, those targets, rather than finger in the air. I think the positive thing is that the ICB, which I'm sure somebody will be here on this meeting, they're working with us on this and they understand our position. So we will keep you updated around these negotiations. And if you have if practice has got any concerns, or if they're told something different from what I'm telling you, please do approach the LMC, because obviously we want to know, we want to hear from constituents around their concerns and whether they hear things different from what we're hearing. So that's, I think, Tammy, for me, a very brief summary. I don't know whether there's anything else that you want to add.
Thanks, Daniele. So I think that's just a sort of really whistle-stop tour about everything that we've been doing. We're really concerned about some of how the decisions are made in North East London. So you would have seen the email that I sent round about the insulin QI project, for example. So just a plea here for patients who are having their insulin administered by the district nurses. Please discuss those patients at your diabetes MDT meetings, because it's really important that we are acknowledging that there is a review that can be done of those patients, but actually it isn't about us having that transfer of work or making sort of last minute plans with carers if those patients aren't having their insulin administered properly. The other update was around the weight management. I had a meeting with Jeremy Kidd, and yes, Nell are sending in referrals, as we've seen on the WhatsApp group, to Aviva under an RTC sort of contract. But hopefully there will be some comms that are coming out about, kind of what the next steps are. I think NHS England have made it quite difficult for the ICB, so just giving them a bit of grace there. But I think there does need to be some more communication, more transparent communication about those difficulties, so that at least we have something that we can say to our patients, because there have been a lot of complaints, and so it would be really useful if we can gather some of that information so that we can pass that on to the ICB as well. And I think finally, just, a couple of years ago, we did a really big piece of work around the LTC sort of framework, and across North East London. And obviously,
times have changed, QOF is changing, the clinical picture is changing, and whilst we've agreed some funding, there hasn't been any agreement on thresholds, and so it's really important that if you feel that, you know, a spec comes out to you, or you've just got some information that you want to tell us, as Daniele said, please do feed that back. It really does help us with those conversations with the ICB about, you know, what's realistic. And I think the care home spec that's come out is really demonstrating the need for us to do that moving forward. So I think from me, I don't think there was anything else, but I've just seen that Parol's put in there about the wound care payment, and I'm not sure that there is anything that we can say about the dates of when that's coming out, but what we are concerned about is the data mismatch. So on the wound care spec, the template is picking up, it seems, a page per patient, and not the fact that there could be potentially up to 3 activities for that patient. So Sadak at Claremont's been very good with his Excel spreadsheet and sort of trying to keep, you know, an eye on that, but it's that kind of detail that we need to be able to go back to CEG and the ICB and say there is a real mismatch between the data and therefore the funding, and this is delaying payment. So that's something that we will continue to work on, but again, evidence of that, I know it's a little bit extra work, but really that's the only way that we can demonstrate, you know, sort of what the difficulty is. So thanks.
Wax.
Thanks, Tammy. Tammy, thanks for all the work that you're doing. Apologies, I couldn't make Thursday's meeting. I had appraisal. Tammy, I was just going to check. So as we're coming towards the end of the year, we're doing a little bit of sweep with things and things like that. And with practice hat on, and conscious that yourself and others are involved in close conversations around enhanced services. Sometimes we don't have patients who are eligible for, surprisingly, for a enhanced service. What then happens to that resource that was earmarked for that kind of situation? How do they work it out? And what happens with that resource? Because one, I don't want to see it disappearing in the bottom line. Two, we need to have confidence that that is reinvested back or spread amongst the other indicators, because you know, there's something about, and I think that's going to happen more when we have like a super NEL-les enhanced service or whatever, or a national kind of situation, just like what happens with QOF and stuff like that. So be interested if that ever gets picked up in your conversations as well. But thanks for all the work that you guys are doing.
So that comes up a lot, right? I think that's been our challenge, about the transparency between, you know, what the budget is, how much we utilize of it, and what happens with the surplus excess. Because I think, you know, we haven't had an uplift in any of our enhanced contracts for many a year, and I think that unfortunately, because of some of the turnover in the ICB staff, there is a lack of sort of organisational memory about some of this, and I don't think that they've been able to find the data in to the detail that we need it in. So it's a continued ask, and I can see Daniele shaking his head. We ask all the time, and it gets to the point where it's relatively embarrassing because we ask at probably every meeting. But we will continue to do so because that's the right thing to do, and we want to make sure that we are ring fencing that funding for general practice, because at the end of the day, we need safe, sustainable general practice. That's what we're here to support you as practices in doing. So yes, we will continue with that.
The problem is, Tammy, that I think, again, with primary care lead hat on and practice hat on, there's some things that we just don't have the people power to be able to do, and actually we are having to prioritize more, and actually I think if we don't see some sort of increase, and I know it's going to be a real challenge, or some sort of simplification or efficiency in what we have to do in a number of the targets, then I think these kind of enhanced services will take a bit of a back seat, and because we've got other conflicting priorities, right? So Ardens, which is relevant, CQC, etc., our QOF work, where we know things are guaranteed, and you know, you can put your money on that we have to complete them, otherwise we'll be in shtick. So I think it's important to build that into the conversation. The other thing I was going to ask, in terms of the conversations with the ICB around refreshing who has those conversations about enhanced services, is I mean, I'd like to be a bit more involved, if that's possible, but from primary care kind of entry point, you guys have been with LMC and stuff like that, but I don't often get called to these enhanced service meetings, but I think it's important that myself or Rima has oversight in some of the changes that are planned. Could that be arranged?
So I think we're asking the wrong people from that respect. I would expect that the ICB would be inviting you, but of course we will advocate for that being an option as well. Obviously, there are some things that happen at Newham Place, and there will be some things that happen at Nell. And I think that we haven't really got the governance structure in place to kind of understand what's happening with that. So, but I think that's a reasonable ask. But Daniele's got his hands up, and he may be able to answer better than I have. Thanks,
I think it's
Daniele.
got lost in kind of that Nell local place kind of situation. So as primary care leads, yeah, we're primary care leads, but you know, where are those conversations actually happening, and where's the governance around that?
Daniele, do you want to add to
yeah,
that?
no, just very brief. Just wanted to say that I completely agree. I think Wax, as primary care lead, you definitely should be involved in those things. But again, it's something that we can raise with the ICB for sure. But obviously, it's then up to them to invite you, I suppose.
Thanks, buddy.
Okay, thank you. Parul, you had your hand up before. Did you have any question?
No, I just wanted to let Temi know that thank you very much for all the work. But when I mentioned about wound care, it looks as if practices are not getting paid in their quarterly payment for the wound care. I have raised it with ICB, but if they have any update, that's what I just wanted to ask.
Okay, thanks. Right. So, Wax, I didn't forget you. I was being strategic, so you have a bit more time. So Wax is kindly here and going to be doing a Q&A session. So Wax is here in his role as our GP rep and also primary care lead. Wax, just, I don't know if you've had sight of Vaishali's put some, she's put 2 examples down of where she's looking for help. So I don't know if you want to start off with helping with that as your first question.
I can't see the chat on my screen. Are you able to just tell me what
I'll
the 2
repeat it if that's
Yeah,
easier.
thanks, buddy.
Yeah, no worries at all. So it's just I just want to know where to escalate. So I think it's useful that Rima and yourself are the point of contact about 2 things. One is, just since last week, Wax, we've seen patients presenting, and 2 that I know of, to us with an email from Royal London, that's where it's come from, to say that your referral has been rejected and we have advised a different course of action to your GP. But when we look on the Cerner portal or on ERS, there is nothing there with regards to whether it was rejected or why it was rejected or what is the different course of action. So this is new. So that's where I thought I'll flag it up here in case anybody else has come across this, or is it just 2 of our patients? But we just didn't know what to do with them apart from just saying we do another referral. But I don't want to kind of keep repeating the process if it's not going to yield anything for my patient. So that was one. Second one was about the ADHD clinics. And I know adult ADHD clinics have longer waits. I was most concerned about the child and adolescents, which I have at least 3 patients whose behavior at schools being affected. And when we first called them, we were told the wait time's about 18 months. And then recently we've been told it's about 3 to 5 years. By that time, the child's going to finish the school. So I just want to know as to which is the best way to kind of help the patients, but also manage the wait times, which I understand nobody wants wait times. It's not a preferred choice for anybody. But if this could be escalated somewhere, especially with the children and adolescents waiting for ADHD assessment, especially for diagnostics, I'll be grateful, because I don't have the heart to tell a patient you have to wait for 3 years or 5 years. I just don't.
Yeah, thanks, Vasali. Good points. Thanks for having me up. And I know Rima's on leave, so I'm stepping in from that place kind of situation. Point 1, Vaishali. Yeah, so there's various routes. So I know LMC and Barts have a regular meeting. Tammy, is that correct? Where such kind of contractual kind of situations are picked up, and that's from the wider kind of situation. We do have a planned care lead now, maybe induction period at the moment, but I would certainly, Vishali, copy myself, Rahana, and Rima in, just to a quick email so we can pick this up. Rima can pick this up in that quality kind of situation that she has with partners, and the same would go with the ADHD. That's a big problem. So obviously, from with GP hat on, or we have things like right to choose, etc., and stuff like that. You would have heard about that. That's absolutely fine. Yeah, absolutely agree. We need to manage expectations sensitively, without undermining not only trust in the services and partners that are out there. So it is a very, very sensitive kind of situation. I've resorted personally to saying, unfortunately, I'm not able to on this occasion document that clearly, but happy to work with you and the family to support you with referring you into the system. Specifically around the ADHD mental health kind of situation, we should be picking this up with Dr. Siddiqui, Imrana, and CCing in Rima, so they can have conversations. And then Tammy, maybe we make a quick note for our next interface kind of situation when that comes round. Yeah, this is not cool, and in the advanced age that we are with IT, really, to be honest, there should be some quick ways to deal with these kind of situations. We need to know what services are available in a live kind of way, rather than message on our WhatsApp group and basically create our own dashboard. Do you know what I mean? I hope that picks up a couple of those points. But yeah, and then if you haven't got time to pick up and send those emails, I'll give it a couple of days, and then I'll just step in and do that for you, no problem.
Thank you, Apna and Wax. Sorry for jumping in before Tammy can even get a word in to add probably to this. But what I'll do is I'll save an email on this occasion, because I was directly able to raise it with you, that I think would be more purposeful. But if it continues, especially with the referral rejections coming through patients, I will put it formally in an email to Rima and to yourself, and copy Tammy in as well. Yeah.
Thanks,
Thank you.
Vishali. Thank you.
Tammy?
Yeah, so I wasn't aware that people didn't know about the integrated front door, but it's a relatively, I think it's been going since about the end of 2023. So I've just popped in the chat bar the information or the link to the website, but schools, GPs, anyone can sort of refer in there. But really, especially Charlie, if they're school-aged children, please do hand that piece of work over to school to manage, because it's about them needing the support plan in school and maybe needing Senko. My sister's a head teacher and actually wants us to stay really clear about it. It's not about medication, it's about, you know, the other wraparound care that they need in school, and behaviour management, educational psychologists, that kind of thing. So I think it's a good service, because it is a kind of a holding area whilst they get assessed.
I will scope this out for this particular child in question, but it is actually the school who's insisted with the mother that they have to come back and chase the referral with us and the ADHD team. And so we always get caught in between this. So thank you for emphasising that to me.
And a lot of the referrals will be rejected if they haven't got information from school. So actually, we do need to push the focus back on school. But you know, when things are hard, it is ping pong.
Anil?
I'll just say thanks, Vishali, for raising it. Just that you know, it's not something new. The team or mental health team actually does know all this, but we haven't actually seen any results or any change. So even us emailing and you emailing across now again, I'm not too sure what we've been doing, Tammy, then for the last 18 months, because we've been raising this, haven't we? They're aware of it and they know. So unless this miracle email is going to change anything, Vishali, then Wax, please do what you can as your lead role.
I will sign my name at the bottom.
Yeah, maybe we'll just get, you know, some miracle happen. I think we also just need to be aware of some real quick wins and some real front door issues as GPs on the ground. We have a very transient population. We have a number of patients coming from other practices outside of Newham who are already on ADHD medication. When they arrive at our door, what happens to those patients? Do we then just simply carry on that prescription when we're not supposed to? We don't have the expertise. Where does that patient go for that medication? There's a big gap at the moment. We're referring to ELFT. ELFT are saying that the patient has to wait 3 to 5 years, even though they're already on medication, and they should just suddenly stop. So what, you're telling the patient to stop medication that they're already on, wait 3 to 5 years to just get another prescription? We can't send the patient back to their previous practice because they moved into our area and we all have catchment areas. So therefore, what does that patient do? I haven't had a result or an answer from anybody on this particular question, but Wax, I don't know if you can add this to your list. What do I do with that patient who's at my front door wanting medication that my colleague in another borough has happily prescribed, but we in Newham, as you know, don't offer and don't prescribe generally ADHD medication? After refusing to see the patient for 3 to 5 years, what do we do?
I feel your pain, buddy. It's like
I'm sure it's at your front door as well.
Well, it's really interesting you say that. About 12:20 before I came on, I just got a task from Martin saying, what should we do about these 2 patients who've just been sent, who've just joined our practice, they're on sulfasalazine, blah, blah, you know, all of that kind of stuff. And are we willing to pick up? One was Lewisham and somewhere, and one is Whittington and somewhere. So yeah, it's you know, we're in there's no doubt the pressure and the challenge is unprecedented, and I admire all of your patience with these kind of situations. I know we need to keep banging at the door.
Yeah,
we need to keep banging at the door, and we can't hide behind CMO medical letters, etc., to say that we're thinking about stuff. We need to keep banging on the door.
And maybe Wax, yourself and Rima, just can put a little bit added extra pressure that we don't need any more new leses. We don't need any more specifications. We need to cut down the existing number of specs that we have in the borough of Newham. Out of the other 9 boroughs across the ICB, we have the highest number of specs. I know we are miracle workers in Newham and we do the best generally, but there comes to a point where we can't take on any more. And why is the neighbouring borough got half of those specifications and we've got double? You know, it doesn't make any sense equality wise. And actually, we've got these issues that I raised today and our colleagues raised on the call. Isn't it about time that we just scrap some of those leses right now and implement that funding into these real issues and problems that we have right now? Is that not something yourself and system leaders can actually just really try and influence? Because we have these les meetings as LMC, we are a vocal voice on the table, but each and every time we seem to just get pushed away, and it's getting further and further that we're actually being listened to really make some change. And I'm not sure what the next steps really are for us as GPs on the ground, except to say we can no longer offer or do any of these services which are additional to our core contract. And do we as GP practices and GP leaders now say we are going to be delivering our core contract only, which we should be able to deliver, which means that we cut the number of staff we have, we cut all our expenses that we can't afford, and actually just do what everybody else across the country does. And the only person who's going to suffer from that is the patients who aren't going to get the enhancement that they need in this borough. So if we don't do anything now, we're really going to struggle over the next 12 to 24 months. And especially from the 1st of April, when national insurance for every single practice is going to go up. So please, please, please do whatever you can to help and support us.
Anil, well said. My red pen is always ready, and hence that sort of request from myself to put it on record that we need to get stuck into these conversations, because you're right. 1 year's gone, 2 years gone, 3 years gone. Organizational memory. When you look across when you get properly stuck into it, into those enhanced services, there's stuff across there that there can definitely be some efficiencies. And there's stuff that we understand that the financial portfolio, despite request and need, might not change. I get that. Absolutely get that. We accept that. But then that whole kind of situation that we do around these extra bits and pieces, there needs to recognize the change, not only in the resource financially and in people that we have back at practice level, and the other pressures that distract us from doing said services and stuff like that. So all of that should be part of the conversation, but absolutely agree with you. And like I said, I've got 2 big Sharpies ready and happy to go through stuff and with a big red Sharpie.
Including the care home, Les, hopefully, and the colleagues on the call have really looked into the care home spec and seen that it's not deliverable, it's not achievable, and the only people are going to suffer is you as a practice, but also those patients when practices turn around and say they're not able to deliver because they're unrealistic targets. So maybe our clinical leads in those various roles need more of a remit around actually being able to influence those specifications to a level of not just strategy and clinical, but also looking at the finance element and the deliverable on the ground. Because I keep getting told clinical leads are not there to support just primary care. They're there across the ICB. They're not just for Newham. They're also there across Bart's footprint too. And the clinical leads, unfortunately, aren't what they used to be, that they're able to influence the finance side of things or the decision making in terms of the templates or targets. So maybe we need to revisit this job specification for our clinical leads to make them more purposeful for us as general practitioners.
Anil, you know Tammy, the care home spec, has it gone out yet to everyone? I mean, we've got 1, 2, 3, 4 care homes, and I haven't seen the refresh spec.
Has gone out, Max.
Yeah, I think I think it went out. Yeah, I think it went out prematurely. I don't think it was meant to have done, but it's out there.
Yeah. So yeah, absolutely. I need to have a look at that before I can comment, but I trust my colleagues. I went on a care home ward round the other day, and that's 48 patients, and it took me most of the day. These are complicated patients. It's a very, very tough time of year, and I had some help coming around with me as well. So yeah, I need to see the spec before I comment, but I trust what you guys are saying, and I'll pick it up with Rahana, who's the frailty lead, and let's look to feedback in the coming meetings. But it sounds like absolutely something needs to be done.
Daniele?
Thank you. Just to say, so the actual revised spec has not gone out. What's been sent out is it's a PowerPoint presentation that outlines some of the key changes. So that's what's gone out so far. And Wax, it's actually the clinical lead for this. It's a GP in Havering. I will send you the name. So that you might know her. Maybe it's worth engaging with her as well.
Sounds good, buddy. And like I said, I have to run around 3 or 4 of these or 4 of these homes on a weekly basis, and yeah, it's not straightforward. Not straightforward at all.
Tammy?
No, so just to say, I think we're trying to get a meeting together, Wax. So I'm just digging out the email, and I will forward it to you if you were missed off of that that list, just in light of what you've said previously.
Yeah, that would be amazing. Brilliant.
Thanks.
Conflicts aside, yeah.
Okay, do we have any other questions or comments for Dr. Wax?
we can usually get an answer to most questions. I've got 3 or 4 things that I wanted to feed back, Pranay, if that was okay
Yeah,
with you.
please go ahead.
Let me just unravel my boots here. CQC, how's everybody getting on with CQC? Happy to take any questions about that. I have been in touch with the regional inspector who's covering North East London and Newham. The understanding is that between 15 and 20% of practices will be visited in the next 12 months. That's the aim for the new under the new regime, the single assessment framework. That's 1 in 5, guys. So how many people on this call? 20 practices represented. That means 4 people. Not want to burst your Valentine's bubble, but let's work together on this. There's a single assessment framework. Make sure that you register with the CQC portal. You do that via Word documents at the moment. All the instructions are on the CQC website. And thank you so much to NHC for enabling us with Teamnet. People might think it's clunky, but I tell you what, for CQC, it does a fantastic job. You can self-rate yourself, and you can see how you're driving, and it helps with so many other things. So thank you so much to NHC for that ongoing support with that, and we use it in really heavily. And just so you know, Agilio Teamnet have a massive partnership with CQC. That means that CQC are looking for Agilio Teamnet as your platform where you do your CQC stuff. And it doesn't have to be any rhyme nor reason as to why. It's up to them. They like this. If you do something different, that's fine. If it works for you, that's fine. But they will say there's also this. Okay. If you have any questions, please, because I know lots of people have lots of sleepless nights around that new single assessment framework, not even the old CQC stuff. Okay. IT, big problems, right? We had that problems before Christmas or in the autumn with all of the outages and stuff like that. A lot of people are telling me around response times when something happens, there's a fire or something, or you need new equipment. We've got new estate and stuff like that. So that's been raised with the SRO for that. I know Laura's on the call. Laura, with myself, Jagan and Mark and the primary collab have raised the challenges that we're facing with Henry directly and Zena. One around responsiveness when things go wrong. 2 around, okay, well, we've all spent a hell of a lot of money on telephony. We've spent a hell of a lot of money on equipment. We're spending money out of our budgets on the e-hubs and things like that, and various licenses and stuff like that. And all of that is impacting cash flow. But we do that because we recognize how important it is to our workflow. And really, how do we, if we're being asked to do more things 24/7 and do things in partnership and stuff like that, absolutely we need to be enabled and supported with not only people power but pounds and pence to be able to pay for some of these products that will bring across these efficiencies. So that's been directly raised with Henry. The other thing is, I did think Jack was going to be on the call, but I think we'll update around estates next time. And yeah, Paryl's already picked up around the wound care payments. The final thing I wanted to mention was, is anybody still having trouble with Walida for their urgent care plan reviews? So we've had a bit of a fix in our PCN. We did email ICB, but actually we've gone directly to Walida. In the bottom right hand corner, when you log in the morning, you see that blue, dark box thing. If you see, there's 3 lines: Universal Care Plan, UCP Information and Resources, and UCP Support. If you click UCP Support, there's some fantastic contacts who will be able to sort out your logins. You'll receive a login kind of set up from them, and that will help you with your enhanced service, your UCP enhanced service, to do your first and second reviews. Okay, that's just the enabling bit. We still need to get on top of the payment bit, I think, and we're still trying to, I think, work with LFC colleagues on that kind of situation. But yeah, UCP support, bottom line in that Valida box, if you're having trouble getting a login and stuff like that. Okay, and there's a nice supportive comment from Paul there around Teamnet. Yeah, it's yeah, make use of it, guys. Honestly, it really will help you. Thanks, Arpana. That's
Great.
all I wanted to pick up.
Thanks so much, Wax. Thanks, that's been really helpful. Okay, so the next item on our agenda, we've got Regina and Yasmin, who are coming to talk about a community cancer project.
Yeah, hi everyone, and thank you for the opportunity to speak to this wonderful crowd today. Just a quick introduction before my colleague comes on. My name is Regina Madweke. I'm the public health program lead for the NEL Inequalities Project, which the cancer screening project is just one of it. Today, I and my colleague Yasmin from Catch 22 will be making presentations specifically around the project. And first of all, would like to share light on the insight we've gathered from the first phase of our project. And then we'd also want to share some of our plans for the second phase, which we have called the intervention phase. About 2 years ago, we received funding from NEL NHS Inequalities to run a core design program in 3 priority areas, one of which we decided was the cancer screening project. And upon that, we have, like I mentioned earlier, we have completed the first phase where we identified barriers to uptake of the services. And today we will go a little bit in depth into what our findings were. And without taking much of your time, I would like to hand over to Yasmin. Yasmin, if you're ready.
Yeah.
Good.
Sorry. So hi everyone. I'm Yasmin and I am part of Catch 22, based in Community Links, which is in Canning Town. So as Regina mentioned, this project, it's part of the NEL Inequalities Program, and we were commissioned by Newham Public Health to conduct this piece of research in the first phase, aimed at understanding the persistently low participation rates in cancer screening among Romanian and Bangladeshi women in Newham. So this project basically, it sought to address health inequalities by identifying barriers to accessing cancer screening services and engaging directly with these communities through outreach and focus groups. So having engaged with 300 women in total, 150 from each group, these sessions help to collaboratively generate ideas with the residents that could increase future participation in cancer screening invitations. So basically, the key findings were language was one of the biggest barriers for the women to access screening. So one of the things mentioned, particularly with the Bengali community, is that educational material is great to have in different languages. However, with Bengali, the written language is in a different dialect compared to the spoken language by a lot of the people within the area. Therefore, sometimes not everyone can actually read the material. The other findings included lack of awareness on purpose of screening, which meant that screenings were not a priority for them, as they don't know why it's needed, what it's for, and what will happen. And then lack of awareness around the signs and symptoms, fear of screening outcome, and misconceptions about risks of getting cancer. So some people think that if they don't know, it means it won't hurt them. So through the focus group discussions, suggestions were that directly talking to the local population would be a key way to tackle a lot of these barriers, with a flexible working team who bring like the appropriate languages and cultural knowledge. Could we go to the next slide, please? Sorry, could we go to the next slide?
It's there, phase 2.
Yes,
Is it phase
thank
2?
you.
Yeah.
Yes, thank you.
Yeah, it's there.
So building on the insights from phase 1, we proposed a telephone-based intervention for phase 2 to focus on cervical screening. So what we'll be doing is targeting women aged 25 to 64 from the Romanian and Bangladeshi communities who have not responded to their cervical screening invitation in all practices within Newham. So the objectives are to increase participation of cervical screening within those two communities, reduce health inequalities by addressing barriers and provide health promotion. Next slide, please. Perfect, thank you. So the calls will take place from Community Links office, which is based in Canning Town. Each woman will receive a call from our trained multilingual help facilitator. They'll use a behavior change and motivational interviewing approach to encourage participation, offering a support in the women's native languages to ensure clear and comfortable communication. So during the call, health promotion will be a key focus. The health facilitators will provide information on the signs and symptoms of potential health concerns, explain the screening process, and emphasize the importance of participating in regular screenings. The team will facilitate open conversations around any barriers or challenges the women may face. And if social determinants or other issues arise during the call, the team will also provide signposting to relevant services for additional support. So this holistic approach aims to not only boost participation in screening, but also address underlying factors affecting healthcare access within these communities. We will try calling them up to 3 times, including evenings and weekends, which allows to catch each woman at a convenient time for them and maximize the reach rate. And in addition to this, the team will be booking screening appointments directly through the EMIS system, facilitating women to access and attend their cervical screening. Thank you. So the next steps. So the DPIA has been completed. We're just waiting on the sign off. So as soon as that's done, we'll be in touch with all the practices. My colleague Nazma Ali, she's the lead project officer within my team. She'll be in touch with the practices to sign the DPA on the DCC as soon as it goes live. And what we'll be doing is we'll run the EMIS searches ourselves to identify the non-responders, so that practices will be asked to provide login details for us, because that will also allow us to be able to book the patients directly into EMIS. So after we run the searches and we identify all the non-responders, we will input all the data into our calling spreadsheet where we can monitor all the calls. And the calls can begin. And usually it would take around a week or so to complete all calls, as we try and call the patients, different times of the days, different days and different times to maximize the reach rate. And as soon as the calls are complete, we will be sending the practices the spreadsheet of the calls that we've completed, so that any notes or anything like that and updating any patient records can be done. And we will also be letting the practices know how many patients we've contacted, how many we spoke to, how many we managed to book. So after that is all done, we will rerun the search after about 3 months, just to see the number of patients that we spoke to and contacted actually attended the screening. And this will allow us to basically kind of see the impact of the project. And yeah, that's basically the cervical screening program. Thank you. If you have any questions, do let me know.
Thanks so much, Yasmin. That was actually really informative. And I think it's similar to the project that Community Links have been doing for years with us with bowel screening.
Yeah,
so
yeah.
I think we've all had good outcomes with your help with bowel screening. So I think I think you'll find that practices will be engaged with this. Wax?
Thanks to Yasmin, you and the team for your presentation. Just a couple of questions. Question 1, when you booked a patient into the practices system, because I saw that was part of the DPA as well, how do you give them a reminder the day before? And secondly, just when information goes round about the project, could you share some of the background data? So I know it seems we're picking up certain communities here. We do a lot of outreach work, and it's, I know, funding aside, but it's not just those communities that tend to struggle with this kind of situation. Those were my two questions. Thank you.
Thank you. So in terms of sending the reminder to the patients, we usually would send a text saying like to let them know the time and day of the appointment that we've booked for them. We wouldn't send a reminder a day before the appointment, because we work on a different system in terms of our Excel spreadsheet, but it is on the practice system. So if the practice does have an automatic reminder system, I'm not too sure. So maybe that they'll be able to do that. But from our end, we'd send them a text with the date and time of the appointment once we've booked them in.
Where does that text go, from your system or our system?
It would go from our system.
From your system. Okay,
Yeah.
good, excellent. We've had to become a bit more creative about reminders, and colleagues will know what I'm talking about. So yeah, if it's going from your system, happy days, happy with that. And then just some background data just to show the exact reason for the aims of the project, why we're going with certain communities. I'll tell you why, because sometimes we get asked questions as to why somebody is calling on behalf of the practice about Project S, but why do you not then call this person? And then we need to respond as well. So just some clear information so we can arm our teams with some of the questions that we come at. Otherwise, we might end up having to send lots of queries to you guys, if you see what I mean.
No, definitely. Regina or Anne might be able to answer that question for you.
Yeah, hi everybody. My name's Anne and I work in the public health team. Regina works on my team, and so I'm the project sponsor. To your question, Wax, so when we started this work a couple of years ago now, we tried to do really deep quant analysis to tell us where the biggest health inequalities were in order to focus the range of projects that we did. And actually, the data wasn't available. And so we then had conversations with clinical colleagues particularly in primary care, about where there were screening concerns. And the feedback from cancer leads was that particularly people who don't speak English or don't have strong English was a concern. And so we focused in on two groups where we knew we had capacity in Catch-22 and community links to support, and also where the primary care colleagues had told us they were most concerned. And what I'm happy to do, if it's helpful, is I wouldn't put it that way around in the public domain, but I can write a kind of version of that I can send and people can use if they're asked. The other thing is that it's a pilot. It's trying to show us how a different kind of how additional capacity, collaboration with community organizations can increase uptake. And as was said earlier, you already know that from the work that Community Links is doing on bowel cancer screening. And so it's a pilot with an ambition to spread practice. So it isn't that it ends at these communities.
That's incredibly helpful, Anne. Thank you. Thank you so much.
Thank you. So Anne, just to clarify, so if we have patients that we think would be suitable for this project, but they're not of those two backgrounds, can they still be part of this project, or is it a no for the moment?
At the moment, no, because it's a pilot and that's the resource that we have.
Okay, sure. There's a question from Laura with regard to when practices will be contacted. I think it might have been on one of the slides, but I don't recall what the contact timing was.
Sorry. So I think it will be in the next couple of weeks for sure, because we are just waiting on the sign off and the DPA to go live on the DCC. And as soon as that happens, then my colleague Nazma, she will be in contact with all the practices within Newham.
Okay, great. Thank you. Any more questions for Yasmin or Regina or Anne? No, thank you. Thanks, Yasmin. We look forward to hearing more about this project.
All right, great. Thank you, guys.
Thank you.
Okay, does anybody have anything else that they want to raise or anything else that they wanted to discuss in this forum? No? Okay. Thanks, Oh, Dr. Sen?
I just wanted to remind people, if there's any changes in the practice regarding partners, retired or registered manager for the CQC has been changed, please inform the CQC immediately, because it has to be updated immediately, because as WAC says, today is the last consultation process happening in the CQC, and after that probably they will be on the ground. So any changes of registered managers, please let them know.
Thanks, Dr. Sen. Wax?
Sabir, can I just add, can practices, if they're going to notify of the changes, make sure they've got all of their stuff ready, because it will trigger a visit. Yeah, it will trigger a visit. So that's not to frighten anyone off. Spend a couple of weeks, ask the questions, get support, whatever you need to do, get CQC specialist X or Y in to help you, but get your stuff ready, and then by all means send your notification. That's the right thing to do.
Okay, thank you both. Okay, so our next forum is on the 14th of March. Maggie will send out the slides. If you need any other information, please do reach out, and have a good Valentine's Day and a good weekend, everyone. Okay, thanks for joining us. Okay, bye.
Thanks, Arpana.
Thanks,
Bye.
Adnan. Bye.
Thank you.
Bye.
Bye. Bye.
Paul, are you able to stay on?
Yeah, sure.
Yeah. Arpana, was that okay?
Yeah, that was good. Thank you for that. That was actually useful. Why is your camera not on though?
Oh, it's just
camera
no, it's just doing some work, so not at my regular station.
Oh, okay. No
Yeah,
problem.
yeah. So there's patients in the background and stuff like that. So what I was going to say was